So back to the host study group to introduce the last section.
Pallavi.
Okay, if she's not there.
Ashok Khurana.
Yeah.
What can I say about him? If I am to introduce Dr. Khurana formally, it will take more than 15 minutes, which organizers definitely not allow at this time. So I'll just say he's the inspiration to everyone in the field of fetal medicine. After listening to his interview, all of us were absolutely mesmerized. How does he manage to accomplish so many academic and extra academic activities in 24 hours is mystery to us. Sure, he has superhuman abilities and his day has 48 hours. So let the sun shine on us tonight. I request Dr. Khurana to take virtual center stage.
Thank you. Thank you very much. That's a very kind introduction. I'm very touched. And moving on to the last section for tonight, we have something very interesting. It's the first time that we are truly discussing the genetics of the central nervous system abnormalities. And in the next 30-35 minutes, we will take you through these. We begin with a presentation by Dr. Manisha, and then we will have a panel discussion. So for the first 7 minutes, a case presentation by Dr. Manisha Buttada. Dr. Manisha, if you could screen share, please. And we're waiting for you to go to full screen mode. Marvelous.
Big thank you to the Society of Fetal Medicine for giving me this prestigious platform on such an auspicious day. Mrs. ABC, 24-year-old, she was a gravida 2, para 1, D1. Yes, she had lost her first child at the age of 1.5 years. It was suspected to be Down syndrome. However, no genetic evaluation was done. It was a male baby and had delayed milestones. The MRI which was done for the child had shown cerebral atrophy. No other detailed reports were available. The patient came to me for NT scan at 13 weeks. The CRL of 66 mm corresponded to 12 weeks, 6 days. The NT was 1.6 mm, which was within the normal centile. On doing, when I was doing the CNS, when I was examining the baby, there were no obvious anomalies seen in the baby. The intracranial translucency, that is the fourth ventricle, cisterna magna, all appeared normal. We did a combined test for the mother, and the risk for trisomy 21 was very low, 1 in 29,504. So we were a bit relaxed, but as the patient had lost her first child, they were pretty particular that they wanted to do an amniocentesis with a karyotype, which was done at 16 weeks, 4 days, and it was normal. She came a little late for anomaly scan at around 21 weeks. When I was doing the anomaly transabdominal scan, and while taking the section for the BPD, there was a few things which were hitting my eyes, and I knew there was something going wrong there. Here we can see there are a few echogenic foci which can be seen anterior to the thalami. As I was further screening, I realized that the CSP is slit-like. The normal ratio of length by width of CSP is 1.5:1. But here, as we can see, it is around 4:1. So the CSP is appearing abnormal. On screening further, when I went to the transventricular plane on the per abdo examination, I realized that the Sylvian fissure is very, very shallow, very, very shallow. The parieto-occipital sulcus is hardly visible. And here again, I can see that there are these few specks of calcification which can be seen. Now, these images have been given to me by Mohit Sashar. Here we can see in this video that these specks of calcification can be seen. You can see here how shallow the Sylvian fissure is. Now we know that once we are seeing something on a per abdominal scan, which is appearing normal, we are not able to put 1 + 1 is equal to 2. Then we need to do a transvaginal scan and see what we can find further. So on doing a transvaginal scan and doing a complete neurosonography of the fetus, the mid-sagittal section showed a very good corpus callosum. The vermis is appearing very normal. The few echogenic foci, which was seen on per abdominal scan, now we know that they are appearing like calcific foci here, which can be seen here also. On doing the transcoronal scan on TVS, here we can see that there are a few specks of calcification bilaterally in the basal ganglia. We can also see a few specks of calcification here in the thalami. These were not seen on the per abdo examination. Now, when we are seeing the transcoronal video, we can see that these specks of calcification in the basal ganglia are seen very nicely. These calcification in the thalami are seen nicely. Same here, you can visualize these calcific foci very nicely, and you can see that the subdural space here is appearing pretty widened. When on the transcoronal plane only, I can see that both the frontal horns are appearing asymmetric, and the subdural space is increased here, suggesting that this could be early cerebral atrophy. Going systematically, we do a TVS right and left parasagittal sections, and you can see the basal ganglia calcification here. No other findings were seen on in the rest of the fetus, except that one foot had a pedal edema, subcutaneous edema. So, to compile all the findings together, there were symmetrical calcifications seen in both the basal ganglia. Tiny specks of calcification were seen in the thalami. There was mild symmetry of the lateral ventricles. However, there was no dilatation. The CSP was abnormal. There was inadequate operculization of the sylvian fissure and the parieto-occipital sulcus. There were prominent subdural spaces suggesting early changes of cerebral atrophy, and there was edema of 1 foot. So all these cranial features favor Aicardia-Gautier syndrome. The other differential that we had in mind was torch. We sent the patient for second opinion to Dr. Mohit Shah sir to Mumbai, who again had the similar opinion. But as the lady had a loss of previous child, and we were not sure about the delayed sulcation and gyration, we decided to continue the pregnancy. At 27 weeks, we are seeing that the sylvian fissure is still very shallow. The parieto-occipital sulcus is hardly visible. We can see the basal ganglia calcification here, and just see the amount of cerebral atrophy that is now happening. So, to come to a precise diagnosis, an MRI was done. MRI did not give us much information except for lissencephaly and cerebral atrophy. All these things were conveyed to the patient and to the clinician. The clinician explained everything to the patient, and the baby was delivered at 28 weeks around. She went into preterm labor. It was a stillbirth, and it was a male child. As we had seen, there was a unilateral foot edema, as we can see here. The other feet is normal, and rest there were no other findings. We had suggested a fetal autopsy, but the parents denied doing a fetal autopsy. So the cord blood was sent for clinical exome sequencing. And when the report of clinical exome sequencing came, it was something very different, which I had never heard before. The diagnosis of the disorder was diencephalic mesencephalic junction dysplasia syndrome type 1. The disorder is in the gene PCDH12. Now, when I read about this syndrome, there was one finding which they had mentioned on ultrasound is elongation of the midbrain. I went back to my images again, and actually they say what the brain knows, the eyes are going to see. So here we are seeing a normal BPD section, and here look at the midbrain here. And now this was the section of the features, and look at the midbrain here. Yes, it is appearing elongated. So this was something which I should have seen, but yes, I did not know it, so I did not pick it up. Thanks a lot, sir. Thank you very much. And thank you, Moisha, sir, for guiding me throughout in this case.
Thank you, Manisha. That was an excellent presentation. We've actually had this very enchanting evening in Nashik tonight with some very, very excellent presentations and some great discussions. And we'll move on to our panel discussion now. And it gives me great pleasure to, of course, ask Dr. Manisha to stay on for the panel. And we have 4 absolutely brilliant panelists. We have Dr. Ratna Puri, who requires no introduction, former president of the Society of Fetal Medicine, an absolutely great human being, a fantastic worker in genetics, and truly the person who sorts out all our problems, both genetic and non-genetic. Thank you so much for being with us this evening. We have Dr. Mohit Shah, who is the Vice President of the Society of Fetal Medicine, who again is a very, very gentle soul, extremely helpful to everybody. He never says no for anything, and you can always go to him for all problems, academic and non-academic. We have Dr. Sanjay Desale, who is from Nashik. He is the chief of the Nashik Radiology and Imaging Association, and it gives me great pleasure to have him on board tonight for some of the questions. And we have Dr. Pooja Vazirani, who is from Mumbai, again, a familiar face on our SFM programs. And it really gives me great pleasure to have her over here again, because with her background in obstetrics and fetal medicine, we really look forward to her inputs to make sure that this discussion goes beyond the academic and into the realm of daily clinics and daily use. And I do hope I don't let you go into snooze mode. I hope my screen share is showing. My screen share is showing, right?
It is.
Yes,
It is.
Wonderful.
Yes.
Excellent. So let's move on with this. Thank you for that great presentation with the final label of, it's quite a mouthful. How did you choose exome sequencing as an investigation? And did you skip in the beginning, did you skip the microarray when you actually did the choice for the amnio?
Actually, we were suspecting Down syndrome. So we did not think of a microarray. We just thought that the affordability of the patient, thinking of that, we did a normal KT, which was normal, and all of us were relaxed. So we never thought of microarray at that time, initially. But later on, when multiple, during the anomaly scan, when we started seeing multiple things, like Microcephaly and cerebral atrophy, yes, we could have gone in for a microarray, but seeing more other findings, maybe there could be a broader spectrum. So a clinical exome sequencing was done.
I see, and that was not done on the same sample, obviously. That was done on cord blood, after the delivery of the abortus, yes. Now, tell me, did we try any DNA storage here to see that on the off chance that such a set of exotic findings does not come up with something on the conventional karyotype?
Yes, the DNA storage has been done.
It's been done. So good. So then we can work on that. Thanks so much for those wonderful inputs. And I have here a summary of what we've just discussed. And my next question is for Dr. Ratna Puri. If I were to send you amniotic fluid in a case such as this and request you for a QFPCR 131821 microarray, would you change this to a clinical exome sequence if I sent you this kind of a summary? Or is it always a sequential phenomenon that we will do microarray first and then go to clinical exome? And some patient counseling considerations as well, please. Turnaround time for these tests, ballpark figures for costs in the private world, and need for additional testing beyond QFPCR and microarray.
Thank you very much. And apologies, I think my brain is functioning at 50% at this hour. So I think one thing I wanted to tell everybody is when a family comes to you like this and they said that the first child has Down syndrome and the child has died, I forget what age you said, Manisha, sorry, it slipped my mind. But if the child had died after birth or, 1 or 2 years of life, I would want to know why a child with Down syndrome has died. And always go back and look at photographs. Okay, that'll help you clinch your diagnosis, because Down syndrome is something everybody can recognize on a photograph. Because remember, in the world outside, any child who's developmentally delayed is equal to Down syndrome. And we all know better than that. And the importance of that is because Down syndrome has an approximately 1% risk of recurrence. Okay. And then secondly, the features that we saw in this, how would we choose the appropriate test? Well, it is not, by the rule of the thumb sequential, that we have to look at a microarray first, and then we have to look at a clinical exome. We all need to understand that a microarray looks at chromosomal abnormalities, a clinical exome looks at genes. When I'm dealing with two affected children in a family, plus minus consanguinity, and I've done a karyotype which excludes the major translocation abnormalities, which is why we'll have a recurrence. It is absolutely correct to go ahead with a clinical exome or a whole exome. Yeah, so that is that. And the other thing I think which is good for everybody to know is you have your clinical handles, which in this case were excellent. You had a calcification and you had Microcephaly. You would put those down into OMIM, which is the online Mendelian inheritance in man. You get a set of differential diagnosis, and that will also help you clinch your case. The second is that,
About turnaround times and...
Yeah. So turnaround times for chromosomal microarray is about 2 weeks. For a clinical exome, the standard turnaround time is about 4 to 5 weeks. But if the family is continuing the pregnancy, we can ask for faster turnaround times, which is about 2 weeks, working weeks, which really comes to about 3 weeks, which is fair enough, I think, now with 24 weeks around the corner. The costs are variable, depends upon your provider and the test that you're doing. A microarray can vary anywhere from 15,000. There are different kinds of microarrays. If you have a low density microarray, which just looks at copy numbers and they may not be updated, then it's as low as 15,000. If you have the better SNP-based arrays, they would be about 25,000. And the clinical exome also varies anywhere between about 20,000. A whole exome is about 25,000-30,000. So that's the general ballpark figure, depending upon the kind of test we are doing. Counseling is very important because you have to. So here, Manisha was very lucky. She said it was a pathogenic variant. I don't know whether it was a new variant or a variant that has been previously reported with a patient. I don't know whether you reviewed literature to see whether Microcephaly is a part of this syndrome. Is it, Manisha?
It can be there, yeah.
Yes. It is reported.
Yes.
Okay, great. But it's very important to read between the lines of all these reports, because we can get novel changes, you can get variations of unknown significance, and they are not equal to disease. So you have to counsel your patients about all that.
Unfortunately, this patient has been told that the first child has Downs, but nothing has been done for it. So they presume it is Downs, but it is not. And therefore, the patient insisted on a karyotype at 16 weeks, which Manisha did in Nashik, just to exclude Downs on patient's insistence. There were no
Which is the
features
correct thing.
Yeah.
Which is the correct thing, because we don't have a diagnosis.
And when such patients come to you, you go by what ultrasound says. You don't have any family history to go by. And therefore, when you have one child which is similar probably, and the second one which has features which fit into Eccardia Gutier. I mean, you can just guess, you use your best guesswork, try and compile everything and fit into Eccardia Gutier. The next step should be what? Microarray or straight away clinical exome. That's that's when the geneticists actually come into play. So when you talk to the geneticist, I mean, this is what I want to actually tell the delegates, that at times like this, you should talk to the geneticist and ask them which should be the better investigation here. And that is probably the better way to go.
Yeah. Thanks, Mohit, for that input. And our next question was really on this, that, how do you communicate, Dr. Manish, how do you communicate with the genetics team under such a circumstance, and also communication with the obstetrician?
So with the genetic team, I gave them my definitive findings. I also gave them that there could be a few findings which I'm suspecting, and may later on, they may evolve as it's a CNS case. And I informed them whether it was a consanguineous marriage or no. I informed them about the previous child which was affected, and then later on left it to them.
So was these long written notes, or was this all on the phone, or
on the phone? It was on phone.
Ah, good. Because, if you send them a whole list, perhaps it would be easier. So I was just wondering, patients often don't carry it with them. And we've actually started WhatsApping now. We never used to like to use WhatsApp, but we now WhatsApp these things right across. But thanks for that input. And a very similar question for Dr. Pooja Vazirani. Any additional inputs when we are on such a case?
Thank you, sir. As already been stated, that it requires a multidisciplinary team effort whenever you see complex brain abnormalities, because they may not be a pointer to common aneuploidies, but may store monogenic syndromes like gene mutation, and therefore definitely the past history of a good pedigree. The index child, as Madam said, Dr. Puri said, photographs are very important for the phenotype of the index child, and any other history from the parents, like what was the reason for the death. Thirdly, when you the 16-week scan may not give an information about the cranial thing, so the routine 18 to 23-week scan is a must, involving all the planes. That will be really good. However, in this case, because the patients were labeled as Downs, and therefore there's one information for past history is Downs without any information, like without a proper karyotype. Let us not be assuming that it was Downs. That's one message for the audience, that unless we have a karyotype, we don't assume it was Downs. And then definitely all the multidisciplinary effort, the obstetrician should be informed, and also cost when it involves prenatal diagnosis. Fluid nowadays, we are shifting from karyotype to microarray, and all the labs do store the DNA. So it's always handy if we do a microarray, even if it's for common aneuploidies, we can do a low resolution microarray and store DNA for such future evolving abnormalities in such cases.
Thank you. It sounds so simple, and yet we seem to miss that step. I'm so glad you highlighted that for us. Dr. Sanjay, in your practice as a radiologist, do you often find that there's a gap between communications in, since we're not part of a huge big center that is everything under one roof? And how do you cope with that, and really with the genetics lab for figuring out these situations?
Thank you, sir. Thank you, Purana, sir. So I'll be speaking on behalf of Nashik more than my personal experience. 4 years back, we had no center in Nashik with the permission to do any obstetric intervention. So we had no choice but to discuss among ourselves and send patients straight to Mumbai, even for a basic amniocentesis or karyotyping.
Mm-hmm.
Yeah. Then with the persistent efforts, we got nearly 10 labs now registered for doing all kinds of obstetric interventions. And they have a good tie with all the genetic labs across the country. And basically good awareness has been created in all radiologists in Nashik, thanks to SFM. Good things, we have all bosses on phone calls, Bimal sir, Mohit sir, yourself, CT Genesis, Dr. Chopde, Puri ma'am, Godbole ma'am. With the help of all them, all the radiologists in Nashik work up all the investigations in detail. Thank you, sir.
Thank you so much. It's so reassuring to hear that, and to realize that technology is really reaching out to people instead of people having to reach up to technology. I'm sure Dr. Ratnapuri really agrees with me on this. It's been her crusade now for over 20 years to push this. and you can see it's truly bearing fruit. It's very reassuring to hear that. And let me move on to our next scenario. And in this scenario, we're going to discuss agenesis of the corpus callosum. So at 19 weeks, Dr. Mohit, what are the primary radiologic findings in the various sections that we take, and what else do you look for and why?
In the axial section is where the normal BPD section you would start suspecting when you don't see the corpus, when the cavum septum pellucidum. And when you go into the transventricular plane, you will see the typical colpocephaly, the teardrop appearance with the pointing anterior horns. And then you are seeing that the frontal horns are quite separated. They are quite wide away from the midline. So this is something that it should prompt you to go into a sagittal section and do a detailed neurosonogram. And when you do a sagittal section, that's the most direct way to say that when you do not see the corpus callosum where you should be seeing. And when you actually, one way to confirm that is to your bang into mid-sagittal is when you are seeing the vermis too well. So using that as a marker, you know that you are in the sagittal section, and when you don't see the corpus callosum there, it's quite evidently absent. You can use ancillary signs like you see the sundere appearance there, that is the calcine gyri just reaching the ventricular walls. If you plot a corpus callosal artery course, you will see that it, instead of following, because there's no corpus callosum, it's not going to follow, it is going to rather go more cranially towards the convexity, what is typically called snake under the skull sign. This is what we predominantly look at. And when you basically, what happens is when you do a coronal section, you will see ancillary findings, like you will see an interhemispheric cyst and the bundle of probes that actually fail to cross over, indent the medial walls of the frontal horns, giving that the Viking appearance to the frontal horns as well. Now, when you find an abnormality, your mind tends to focus more on that abnormality per se, but there's much more to say, because there's a 20% chance of aneuploidy. There's almost associated with a lot of syndromes, and most commonly you can have associated neural migration disorders like polymicrogyria, like Microcephaly. So what you need to do is extend that neurogram beyond the diagnosis of agenesis of corpus callosum and try to look at the parieto-occipital fissure, the ciliary fissure, and the rest of any additional anomaly that you can pick up.
Thanks so much, Mohit. That's really excellent. And moving on to genetics for this, this is what we find when we're onto the internet and we're doing our Google search. And I get completely put off when I see something like this, and I wonder whether I should just refer this patient to somebody else. Now, the patient comes in full faith, and we can't afford to do that. So that's where we always get hold of genetics. And so my question then goes to Dr. Ratnapuri. In the face of this long list and this completely bewildering array of genetics, how do I handle this scenario? If the anatomical suspicion is discovered late, say at 30 weeks, what do you suggest as an evaluation protocol?
Thank you. Just before I start, I just want one clarification. Till what gestation do we follow up to definitely say that it is an abnormal corpus callosum?
So we do know that this section of Mohit, would you like to answer that for us?
Can I just hear that question again?
At what age do we declare the corpus callosum agenesis?
Yeah, we generally prefer to do it closer to the 20th week, because that's when we really clearly see it. Unless we are, of course, getting a good transvaginal section, but I personally prefer 20th week because that's when it is very well seen. Even the cavum septum sometimes at 18 weeks becomes difficult, and therefore 20 weeks is, I believe, the right time to look at it with confidence.
Thanks. Yeah. Thank you. So it's very simply put, like Dr. Mohit said, how would we approach testing if it's isolated or it has associated malformations? Where we have associated malformations, whether they are those of the central nervous system or extraneural, the prognosis is not good. Saying that, even though the prognosis is not good, we need to understand why something has happened, because it will help us guide future reproductive options. So first, let's look at the non-genetic things: teratogens, diabetes, it could be infections, the torch group of infections. So those are things that have to be looked into. Once that has been sorted out, then we look at chromosomal, which is there in about 20% of cases, 20 to 30% if there are associated anomalies. And another 15 to 20% are single gene disorders. Now, the single gene disorders can be just associated with an isolated corpus callosal abnormality. It can be associated with abnormalities which form part of multiple malformation syndromes, or it could be associated with metabolic disorders. But it will all come within your cohort of single gene disorders. Now, when we have an isolated corpus callosum hypoplasia or agenesis or absence, in that case, we know that if we are able to rule out genetic and teratogens, 70% of those are normal. But to tell you the truth, I really don't know anybody who's identified early to continue, because there's still a 30% chance of intellectual disability, which is not small. Again, here, the extent of anomalies are less, in the sense that about 10 to 15% would be of chromosomal, another 10 to 15% are single gene, and we would evaluate for them in a similar manner. Now, where we have identification at 30 weeks, for whatever reasons, you cannot discontinue a pregnancy there. And here in my mind, it is absolutely vital to evaluate for a genetic etiology, especially if it is mild, because remember there we said that 70% of them could have a good outcome, a normal intellectual outcome. So there I would do a microarray and I would do a clinical exome. And because I'm at 30 weeks and I may not have time to do them sequentially, I would do it together. The reason for that is, if it's non-genetic, I would give the family the benefit of doubt that it's an absolutely isolated malformations, because in 10% you can find things after birth. And you may want to do a cesarean if it is required for a fetal indication. However, if it is of a genetic etiology which doesn't have a good outcome, you have counseled the family and you have discussed with them that this is really going to help you to plan the mode of delivery. Then if they are okay not doing a cesarean for a fetal indication, you would take it forward accordingly. But I think it's very important to keep the family in the loop all the time, because you and I are nobody to decide what they want to do with a baby. I have children of trisomy 18 under my follow-up where they willingly continued the pregnancy because they didn't think in their minds it was correct to discontinue a pregnancy. So there are all sorts of sentiments, and I think we have to be very sensitive towards that. As you know, we find more and more anomalies on antenatal scans.
Thank you so much for so many inputs in such a short time. We will look differently now at corpus callosum. Moving on to our next scenario, and this question is for Dr. Pooja Vazirani. How do you give a label of mild cerebral ventriculomegaly at 20 weeks? And how do you proceed to add the isolated label? And what do you plan next?
Mild cerebral ventriculomegaly, as defined by the ISWOG and the Society of Fetal Medicine International Guidelines, they say that it's in the 20 weeks or in the anomaly scan, when you see the transventricular plane, you measure the atria of the ventricle in a particular manner. That is, the cerebral hemispheres need to be midline, equidistant from the midline. You need to see the anterior area with the CFP, the frontal horns, and the posterior area with the proper occipital horn demarcated well. You should see the parieto-occipital groove, and that's the area where you have to measure the lateral ventricle, inner to inner margin, and the axis should be perpendicular to the axis of the lateral ventricle. This is the measurement criteria. And any measurement between 10 to 12 millimeters is defined as mild lateral ventricular megaly. Now, the checklist to say that it is isolated or non-isolated is first to do a detailed survey of the fetus from head to toe. It involves the fetal neurosonogram guidelines by VSWAP. Part 1 and part 2 have detailed levels, like you need the transaxial, sagittal, and the coronal planes. Second is the fetal echocardiography, and again, the detailed structural part of the baby. Counseling of the parents should be done because it's associated with variety of chromosomal problems, single gene problems, and evolving CNS problems, that is extracerebral and cerebral. So to rule out common problems, amniocentesis is to rule out your chromosomal abnormalities, do a QF-PCR with an array again and store the DNA. Infection screen as well, especially for cytomegalovirus and toxoplasmosis, needs to be done irrespective of history given by the mother or any symptoms shown. And definitely the DNA will be stored to see evolving CNS abnormalities in these babies, because some part of the ventricular megaly becomes progressive, and then they are associated with high risk for neurodevelopmental problems and other neuronal migration issues as well as we move on. Follow-up in all cases of mild lateral ventricular megaly is essential to see for regression, because if it regresses, you can give a favorable outcome to the parents during your counseling session. The follow-up should not be less than 2 weeks in these cases. Fetal MRI in cases of mild ventricular megaly is again a debate, that if the sonography has been done by an expert with good hands on fetal neurosonogram, then ultrasound can be the first line modality. However, if you have experts in MRI who can give you a good additional parenchymal diagnosis, it's ideally recommended beyond 32 weeks to give a good information about the parenchyma, because there are 1 to 14% chance that you might get something on MRI which has been missed on your earlier assessment on ultrasound. However, again, this has been given, like the importance has been given to ultrasound more if you're well trained. And of course, postnatal evaluation of a baby is essential to call it a true isolated, because it can have a prenatal implication and a postnatal neurodevelopmental delay in such babies. And a recent systemic analysis by Professor Baski says that the association of neurodevelopmental delay in these mild ventricular megaly cases, where things have been normal initially, is 7.9%, with slightly higher than the general population, which is about 2 to 3%. However, 7.4% are false negative abnormal ultrasound, which were found in these babies delivered with no associations on ultrasound. So these points will help us in counseling the patient. However, if everything is fine, the counseling should be in favorable note, because many babies, more than 90%, do very well. And the survival rate is between 93 to 98%. So mild ventricular megaly checklist, if that's fine, we need to give a good assurance. However, with a strict vigilance and monitoring of the baby postnatal as well, with the pediatrician as well as the geneticist if required.
Thank you. That was very useful inputs. May I put into perspective one last bit on that, and that is that when we give the label of isolation, Baski Dilnathan in his meta-analysis clearly told us that it's a postnatal label. And yet we need a working label so that we can work up a case. So we do understand that when we say isolated in the antenatal period, we are working on a particular guideline, but we must counsel our patient that isolated may not always be isolated, and 10% would show up some surprises in the postnatal period, and therefore we cannot promise them the world. Would you agree there? Yeah. And Dr. Ratnapuri, back to you. The genetics of ventricular megaly, please. And how do you give us a final diagnostic label? And how is clinical severity and recurrence predicted over here? Because as usual, when we try and study the subject ourselves, we seem to be a little stuck with what we end up seeing. And we find that, oh my God, so many syndromes. What do I do?
Pooja has covered a large part of it, but I'll just put it very simply, that it's very important to prognosticate for mild ventricular megaly, because that is where the family is going to opt to continue the pregnancy because 90% we are saying that things are going to be fine after birth. So where we have isolated mild ventriculomegaly with the caveat that 10% may have additional anomalies after birth, we've ruled out infections, which is also very important. And we would look at chromosomes. The commonest is, trisomy 21. But, you would do a QF-PCR with a reflex microarray in the sense, which means really that if your QF-PCR or your FISH, whatever you are doing, is abnormal, you need not continue on to the second one, and you could refund your patient the rest of the money for the microarray. However, if your first 5 chromosomes are normal, an additional 10% of abnormalities are identified on the microarray, and that needs to be done. And if the microarray is abnormal, I would go ahead and do a whole exome sequencing. I'm a little more biased towards whole exome because we don't have absolute fetal phenotypes for a large number of our cases, and we need to look in deeper. That is probably because I look beyond a report. But otherwise, I think for clinical practice, maybe a clinical exome is good enough. What I want to tell everybody is that when we are sending off a microarray or a clinical exome, they do take out DNA from the fetal material. So you don't have to pay extra for DNA storage. You just have to request the labs, or you need to find out. Very often when I've gone back to labs looking for DNA to do further studies, they have a timeline for which they store DNA. So all those things must be known, because every lab has their own protocol. We store DNA for 10, 15 years because you don't know when it's required. But of course, I may not have the turnaround times other labs have. So it's important for everybody to know for how long that DNA is kept, because, supposing that first child had some DNA, or you find out from the family, do you have an umbilical cord? Lots of them keep umbilical cords. And I have even retrieved those to confirm a particular mutation in a family. So there's a lot you can do. You just need to communicate with the families and know as to for how long your lab is storing the DNA. So if all that is negative, we know that 90% in isolated mild ventriculomegaly, the prognosis is good. They have studies where they followed up children till 3 to 4 years of age. They've done our basic the Vineyard adaptive behavior scaling to look for development, and that has been normal. So that's a very good prognosis, especially if it's, 12 millimeters and less, it doesn't progress in pregnancy. These are wonderful outcomes. For the rest, it's important to have a definitive diagnosis, again, by doing an array or the gene test to be able to prognosticate for subsequent pregnancies. So that is essentially how we work out even the ventriculomegalies. There are a large number of syndromes. There's atherosclerosis, acardi. One very important thing for ventriculomegaly is that a large number of them are males. And the reason for that is we have specific X-linked ventriculomegaly syndromes, the L1-CAM related phenotypes, where there is aqueductal stenosis. I think this is one of the few obstructive ventriculomegalies with a genetic basis. The rest of them are all communicating. And I don't know whether you can look for that on your ultrasound, but that really helps. And you might get pedigrees with an X-linked pattern of inheritance. And it's not so rare. We've seen many cases of L1-CAM related phenotypes.
And when we look at the exome sequencing, is it always a trio sequencing involving the parents, or is it just the amniotic fluid?
Well, that's ideal. A trio sequencing is ideal for variant identification and filtration of non-pathogenic variants. And if the costs come down, I think that is what I would recommend, really. But I don't know how practical it would be, taking into account the costs.
We're struggling to bring down the costs on that as well, just like we've struggled with NIPT and succeeded partially. I do hope we have good news by next year on that as well.
So can I say, ma'am was asking whether this X-linked can be identified on ultrasound. So if you have a history of male fetuses with hydrocephalus in the earlier, we do look into the thumb of the baby because these are known to have adducted thumbs. So that's one sign where we look into whether there's a proper history of losing male child with hydrocephalus. So, and that's I think the only.
That's the Massa
Then,
phenotype. So this comes with 4 phenotypes, Pooja. One is just an isolated ventriculomegaly. One is this Massa syndrome where it has the adducted thumb and later onset shuffling gait and spasticity. And one is an adult onset hereditary spastic paraparesis.
And for our label of ventriculomegaly, we do know that literature guides us that for all the borderlines, all the 9.1s, the 9.9s, the 10.4, the 10.7, we do need to do a fetal sexing because there is a distinct difference between ventricular size in males and females, and it might push the balance one way or the other. So there again, we must use our discretion depending on the local PNDT environment to actually go ahead and do a fetal sexing. We move on to 3 or 4 very short scenarios. And my question for Dr. Sanjay here now is a brief overview of Holocross imaging findings, please. And do you always do a vaginal scan?
I'll answer the second question first. I do TVS for each and every patient's of NT scan and early aneurysm scan up to 9-10 weeks unless patient refuses to do. And the first one, Holocross, as the name suggests, is a congenital anomaly of the prosencephalon, the forebrain of the fetal embryo. It results from the incomplete cleavage of the forebrain. Depending on the severity, it has 4 types: allobar, semilobar, lobar, and the newer one, centenencephaly. The allobar, there is a complete non-separation of the cerebral. There is a large monoventricle, the uncleaved thalamus. In semilobar type, there is a fusion anterally and the posterior part are separated. The lobar, there is separation of the anterior and posterior, but there are some parts there is no separation, like partial fusion of frontal horns, the absence of CSP, the corpuscular anomalies, and olfactory anomalies. And in centenencephaly, there is anterior and occipital fissuring, but there is no cleavage of the parietal. So we got a vertically oriented ciliary fissures. Of these all 4 types, the 3 types other than lobar can be diagnosed earlier. And for lobar, we need to diagnose beyond 18 weeks. This is basically midline abnormalities. The UG findings are predominantly absent CSP, corpuscular angiogenesis, interhemispheric fissures absent, large monoventricle, uncleaved thalami. There are facial abnormalities like proboscis, cyclopia, cleft lip, cleft palate. Yes, thank you, sir.
Thank you very much. And of course, we do realize that we're now diagnosing these earlier and earlier, even at the level of the 11 to 14 week scan, and definitely by about 15 to 16 weeks. The question I have here is that in terms of doing a formal, when we look at these things, now this input from Dr. Sanjay is very important, that there are different varieties. So Dr. Pooja, is genetics the end of the story in Holocross, or are there non-genetic causes as well?
Yes, Holocross has heterogeneous etiology and beautifully written by Wolf et al. That it got this chromosomal, monogenic, and teratogenic etiologies. Monogenic and chromosomal, they will be genetic, while teratogenic is associated with diabetic embryopathy, the retinoic acid embryopathy, and fetal alcohol syndromes. Along with that, certain drugs like salicylates, anticonvulsants, and infections as well, rubella, toxo, and CMV. These are some cases involved with Holocross. These are the non-genetic associations, and therefore a multiple hit hypothesis was known to be given to the etiology, where you can see a different variability in presentation and association.
Thank you so much for that clarity. And we move to our famous list. And the moment I see these lists, I quickly dial. And then I fast dial on my phone, Dr. Ratnapuri, what do I do next? And she says, okay, send them over, which is really very convenient. And so how do we handle this bewildering variety of genes? How do these act and interact, and how is the prognosis arrived at in familial forms? And would you prefer a CVS or an amniocentesis?
So I would start with a family history. I would look for, because there's a very large genetic component for Holocross. And so I would look at details of previously affected children, I would want to look at the parents. I would want to see if they have hypothyroidism, if they have a single central incisor. These are the minor, what we call forma frustrae of holoprosencephaly that can be present. And they may intellectually be normal. If you do an MRI, they might have an interhemispheric cyst without any phenotype as such. It's important because here your recurrence is up to 50%. So that's really big. Then you would, so I've talked about family history, consanguinity, looking at parents. She's talked about teratogens. And then I would go and see, are there features in the ultrasound that suggest a common trisomy 13, which is the commonest aneuploidy. So it cuts a very long story short, and you do your the common 5 chromosomes by whichever technique we want to. Now remember, because we have a large genetic component, I would like to do a CVS. And the reason for that is you get a lot of fetal DNA there. You need DNA for the microarray, you need DNA for your single gene disorder studies. If we take amniotic fluid, and especially if it is early at about 16 to 17 weeks, very often the quantity of DNA is less and the lab may need to culture the amniocytes. Otherwise, if you take it at about 18, 20 weeks, it's okay. There the quantity of DNA is better. But I would always prefer a CV sample if the family has come early. And when we come to the single gene disorders, it could be syndromic or non-syndromic. So you look for additional malformations in the fetus. So if there are multiple malformations, your array is normal, you must do an array because chromosomal causes are about 25 to 50%, out of which only half of are aneuploidies and the other half are structural variations or copy number variations you find on an array. About another 15% would be monogenic, which could be part of multiple malformation syndromes, like you have Smith-Lemli-Opitz syndrome, Kalman syndrome. There's so many syndromes like that. Or it could be just a change in a gene which causes isolated holoprosencephaly, and that is also well known. And these are some of the genes and the changes that may also be present in the parents. So whenever you find a gene with a single change, which is say heterozygous or an autosomal dominant disorder, you must segregate that in the parents to see, is one of them carrying that change? Because we have concepts of incomplete penetrance. That means the gene mutation is there, but it is not fully penetrant and causing a phenotype. So that is a concept which is very important also when we are evaluating for these sort of changes.
And for this incomplete penetrance, how many generations can we skip?
Well, you can skip 1, you can skip 2. Usually we skip 1. Very often, these large affected multi-generation families are not as common. They are prototypes, very easy, but not so common. So very often we may not have a family history. We get a change in the fetus or the child, we check the parents. We know that some disorders have 100% penetrance. So if that change is present in a parent, I know that that change is not causing disease in my affected individual. However, for disorders like holoprosencephaly, where penetrance is not 100%, I can still attribute, depending upon the attributes of that mutation. There are specific criteria to describe the pathogenicity of a mutation. They're described by the American College of Medical Genetics, which we all follow. If it fits into those criteria, and reports in literature do describe the possibility that it can be pathogenic, then I would consider it pathogenic or likely pathogenic. But just for everybody, since now everybody is into so much of testing, the pathogenicity of a mutation can only be defined 100% by doing functional studies, not by what I think fits the phenotype in a fetus. So things change over a period of time, so we have to be very alert. And I know for a family where I had attributed a change which was likely pathogenic in that family. 2 years later, we found a new gene, and that likely pathogenic change just went out of the window. So we have to be very, very careful, especially when we are doing prenatal testing. I mean, it's only a word of caution.
Thank you. We have another scenario, and the question goes to Dr. Mohit Shah for microcephaly. What are secondary and primary varieties, and what are the diagnostic criteria, and when is this usually diagnosed?
Microcephaly simply means as a smaller brain. So generally, it could be a genetic, a single gene disorder. It could be associated with multiple syndromes, and that's the primary one that we're talking of. But it could also be acquired by infections like TORCH, acquired by Zika, or maternal abuse like fetal alcohol syndrome, or even maternal uh, I think it is phenylketonuria can also lead to microcephaly. Now the problem is this generally starts lagging uh, beyond the second trimester. So most of the microcephaly would have a normal ultrasound in your second trimester anomaly scan. And once the head circumference is 3 standard deviations or less, that's when we say it is microcephaly. And the useful thing is to take a sagittal section of the fetal face, and you would see a sloping, slanting forehead. And that's a very good confirmatory sign that indeed the brain is indeed small. And you can also look at the sulci and gyri, and you will find that there is an associated lesion cephaly that is eventually going to lead to neurodevelopmental delay. The problem, however, is because of this intense bone shadowing due to a small skull, this indeed is a very difficult to look into the brain when you really have a very small brain. But this generally is a progressive disorder. So when you have a suspicion, you generally follow them up and see the head circumference dropping. So the growth centiles are very important in when you want to diagnose microcephaly. If you have it single on, when you see that it's 3 standard deviation or less, you can say it is. But it's generally a late second trimester and the third trimester diagnosis.
Fantastic. And this is that list that we use as a working list, at least when we're working on a radiological platform. Yeah. And it seems very sort of, intimidating, but if we just follow our standard protocol, we'll actually pick up most of these conditions anyway. And what about cataracts? Should we routinely look at the lenses whenever we see something, or should we always include the lenses irrespective?
No, we should, because we know that microcephaly is very often associated with syndromes. So when you see one abnormality, you're obliged to look at the entire fetus. Of course, you got to know that there are certain conditions that go hand in hand, like at the Walker-Wahlberg, where you see microcephaly very often, and that's the time you look at the cataract. When you know it, you can look at it, but generally you're supposed to look at the entire fetus in toto to identify whether it is an associated malformation.
And then would you go as vigorously to try and identify polydactyly as well, so that you could differentiate some of these?
Well, you could, if you really, I believe when you pick up an abnormality, you try and put the entire spectrum into OMMM, that is the Mendelian inheritance pattern, and see whether you can put everything into one and try and localize the syndrome, if it is possible. It is not always possible though, but the commoner ones like the Walker-Wahlberg, the one that we know, Miller-Dacre, which is associated with lysencephaly, and chromosome 17. So we know all of that. So maybe those ones can be easily picked up if we know what to look for.
Great, thanks so much for that. So back to you, Dr. Ratnapuri, genetics, non-genetics, and recurrence counseling, please.
So, in the latest classification of cortical migration disorders, microcephaly comes as the first group.
Right.
And within this microcephaly, we have primary, secondary. Secondary would be something like if you're finding fused sutures, so craniosynostosis, that would cause secondary microcephaly. Primary microcephaly, I think commoner than genetic syndromes would be intrauterine infections, because we know that cytomegalovirus is not so uncommon. It's commoner than genetic syndromes. The rest of microcephaly is Is it associated with additional anomalies? Is it isolated? Is there just a small brain with a normal brain structure? That is the true primary microcephaly that is associated with all our ASPM mutations and things like that. But where we have associated abnormalities of cortical migration, like lesioncephaly, then we decide, so all abnormalities of cortical migration, we need to do a microarray first, because it is not very easy to differentiate whether it would be chromosomal or monogenic. So here I would follow the rule of thumb that we do a microarray, and once we've sorted out our microarray, then we go on to an exome sequencing, because there are so many genes. I mean, we do have some sort of prototypes when we look at a brain, say lesioncephaly. I can say it's a tubulinopathy and all, but it doesn't fit it like that. Even when I look at postnatal cases, very often I cannot fit them into a specific phenotype, because only 60% of microcephaly is sorted out. It's not as if we know everything. It's a big challenge, microcephaly. I feel holoprosencephaly, ACC and all are not difficult to sort out, but microcephaly is quite a challenge. And you need to get to the bottom of this, and especially because they are identified late in pregnancy. So very often what happens is sometimes the families go XYZ place and the pregnancy is discontinued. So it may not be a good idea to save DNA before they leave you. And then you tell them, whatever happens, come back to me and let us do the workup. And,
Actually, then it's very, very complicated, is it?
It is.
Yeah.
It is a little complicated. See, if you get a common something like one of the aneuploidies and all, it's very easy. If you get a copy number variant, most of them are de novo. It's not so difficult. But if you get the recessive common primary microcephaly, so you know, if it's a simple small brain, it's easier to identify the genetic variant, because we have about 7-8 genes that cause primary microcephaly, and they are all recessive. But when we have other I'm struggling with this family where they have a 8-year-old child with primary microcephaly and a typical sort of a Seckle phenotype, short stature. And actually, when I saw that child, I told my residents, so easy, come on, make a spotter and let's get the test done. And God has punished me for that, because I still don't have an answer there. They had a second fetus who again at about 28 to 30 weeks developed the same microcephaly. So we've put him up into a one of the rare disease undiagnosed projects. And we've just done a genome sequencing and trying to figure out what's happening. But sometimes you really get stuck with them and they need workup, because they are recessive disorders. You cannot pick them up early by ultrasound. So how are you going to help these families unless you come to a genetic diagnosis?
And what is the turnaround time for genome sequencing?
Doing the genome sequencing doesn't take time. You'll get the genome in 5 days, in 3-4 weeks. But analyzing that data and making pipelines for that data and figuring out, I think right now genome sequencing we will still put into a non-clinical practice mode. It's difficult to analyze. It's slowly coming into clinical practice, but I think it's way beyond the 5 weeks of interpretation which is required for an exome sequencing. There's just too much data, but it's got crazy advantages. Once we are doing genomes, we may not need to do microarrays. You'll pick up copy number variants. You'll pick up non-coding regions of the genes. You pick up a lot more on genomes.
So that's perhaps the way we should start thinking of in the future. And it again reiterates the fact that teamwork is of the essence. Moving to the last, well, one minute each, if I may say so. Question for Dr. Moicha. How do we suspect a neuronal migration disorder and the role of MRI, please?
Yeah, it's just one of the conditions which leads to a smooth brain. So when you see a smooth brain, you look at the sulcations and gyrations. So we have timelines for the sulci and gyri to develop. So if you see, look at the Sylvan fissure and timeline it. If you say it's shallow, not yet opicalized, that's one of the ways you can suspect that you need to look into the details. You look at the ventricles do appear prominent, but if you see that to be nodular, we know that there are 3 types of this disorder, one with proliferation, one with migration, and one with over-migration, that is organization. So when you have this perinodular, periventricular nodular heterotopias, they're seen generally as bumps on the ventricular walls. That is one way to look at them. And if they over-migrate, you can have, a cobblestone appearance of the brain, which is not always possible to look at unless you are actually doing advanced 3D, and when the subdural spaces are prominent, you can actually look at the bumps on the exterior on the cortical surfaces to say that there's a cobblestone appearance there. So mainly it's one of the major head start is looking at the Sylvan fissure. And sometimes, of course, you can, when you have Schizencephaly, it could either be an open one, so obviously very easy to see, but you can also suspect a closed lip Schizencephaly on ultrasound. So MR does help when ultrasound, in a sense, is equivocal when you're suspecting closed lip Schizencephaly. When you want to find out whether there's cortical heterotopias at that point in time, MR would reveal more than what ultrasound shows. So MR is typically done preferably beyond at 30 weeks, will give you much more information. But if you have done a good ultrasound and you have identified the pathology, but only problem is that it is a progressive thing, and we know that we cannot expedite embryology, and this whole sulcations gyration goes on till the end of term, but generally 26 weeks is when we can see an operculation, a nice operculation of Sylvan fissure.
Dr. Nazirani, your inputs, please, on how we handle these migration disorders.
The clues to neuronal migration, which are again a very complex and evolving CNS abnormalities. The first stop when we see a baby in detail is at the anomaly scan, and that is the time where the clues will work to call her for a follow-up. So the first important clue will be the biometry, microcephaly or a large head. Second is the sulcation, as said by Dr. Mohit. The lateral sulcus is given a lot of importance, whereby you see them at 20 weeks, 22 and 24 evolving the Sylvan fissure. The subdural space is one more clue, which will help you to follow up these cases. There's a large subdural space is a sign of evolving Lissencephaly. Again, ependymal cyst, as Sir said, lateral ventricular megaly, which may be very subtle, maybe 9.8, but then the other clues can call the patient for a quick follow-up. Polymicrogyria, especially if there are other associated abnormalities like a skeletal dysplasia, thanatophore, where you want to see the temporal lobe. So those areas, what the mind knows, the eyes will see, as we have already discussed in the past. So these are the pointers to migration abnormal things. Again, symmetry of the brain, asymmetric ventricles, again, like the acardi, they are known to have neuronal migration issues as well. So pointers will be those subtle abnormalities which we see at anomaly scan. Do a complete neurosonogram, and depending on what you suspect, the follow-up will be depending on that. Because again, migration, unless there is a family history where the patient is coming to us, we won't be able to diagnose straight right on the anomaly scan. So again, patients with familial history of CNS abnormalities, again, need to go to a complete sonogram, neurosonogram, and followed up accordingly, depending on the history and genetic evaluation by the geneticist. Again, a multidisciplinary team will be important for neuronal migration disorders.
Perfect. And so we just come to the genetic aspects, and Dr. Ratnapuri, please.
So after we've excluded infections and various teratogens, etc., then it depends upon the kind of abnormality that we are seeing. So if there's a large brain, so it's within the overgrowth spectrum, then the pathways that we deal with are different. They are the PIK3CA pathways. That's where we usually find most of the abnormalities. And so what I really want to say is, none of us can remember all the genes, and we are not expected to. But why is it so important to phenotype? because that helps in trying to find the needle in a haystack. And that's exactly what is happening, is finding a needle in a haystack. And there is GBs of data, and out of that GBs of data, you have to find one change in a gene. And actually, when you look at the Excel sheets of the data that come, there are so many changes, and you have to filter those changes and bring it down to that one change. So the way you filter it is by giving your phenotype. So you would say a small brain. And I've talked about this before, and I really want to reiterate, because see, the genes remain the same, the chromosomes remain the same, but how are you going to approach it in a specific phenotype is by putting it down into what I call, what is known to be human phenotype ontology. It is HPO. And when you send off your samples for the testing, that is absolutely mandatory. If you all have gone into OMIM and you look into the synopsis of OMIM, the terminologies there are HPO. If you put terminologies which are not like that, you will not get your search on OMIM, or you won't get a good search anywhere, because that's standardized nomenclature world over. So that's one concept I would like to introduce everybody to. And so you would say small brain, you would say microcephaly, you would say lesioncephaly, you could say schizencephaly. This is what I call good handles. And it is these good handles which will help you reach the relevant gene. So that's how we go about it when we are trying to find the gene. If you send off your sample without good data, you will probably get back a report which says no variant identified. So that's really relevant, I think.
And in terms of putting these handles in, should we put the rarest one first, the most common one first, or?
Yes. No. So if I give you a very simple example, if I have a fetus with holoprosencephaly, if I put in hypertelorism, it's a very poor handle, because anybody will have hypertelorism where the two eyes have an increased distance between them. But if I put in holoprosencephaly, or I've put in a proboscis, or I've put in a single eye, they are really very good handles. So the rare, uncommon handles are the better handles than the common handles. If you put in a common handle, you'll get 1,000 differentials.
And of course, the service is free if you ignore the initial notice that comes. In terms of the OMIM.
It's a free website. It's a wonderful website.
Yes, so
you just need to play with it to learn to use it well.
Yes, and to use it regularly, Tuesday evenings and Thursday evenings. Thank you for that. And I was going to throw this as a challenge case, but we don't really have time for that. This is obviously a missing corpus callosum. Ventricles don't look right, depressed bridge of the nose, cataract, and crazy tracts, again, representing the corpus callosum. So when I get a report like this, then how much of this should I handle on my own as a clinician or a radiologist, and how much of this should we leave to the bosses?
Who is that for? Is that for me?
For you, yes.
I would really like inputs from everybody else, because, well, I think it's very important to, you can send off your result, but how to read that result is you can send off the test, but how to read that result, I think, is very relevant. Because what I see is that a lot of changes that are reported may not be actually associated with the disease. And, if it's something as obvious as this picture, I felt very nice that even I could tell you that, well, I don't see the corpus callosum there. But if it's very subtle, I cannot pick it up. So that's where you need the expert. And it is the same thing which is really very relevant in evaluating a genetic report. It happens for copy number variations also. There are so many copy number variations which we just rubbish and we say, well, this is not associated with the disease phenotype. So, everything has to be evaluated well before we say that, yes, this is causing a disease phenotype. And I think it's relevant to form your multidisciplinary teams and to be in touch with somebody who has some insight into all this, because one person can't do everything, because then you just do everything superficially.
Thank you for reiterating that. And we have two quick questions to wind up tonight before Nashik goes to sleep. And thank you, Nashik, for being so patient with us. Dr. Ratnapuri, please tell us about the 30% of neural tube defects where folate deficiency is not the cause.
So it could be, they say, at about 2 to 10% are associated with chromosomal disorders if they are isolated neural tube defects or associated with malformations. Then we have many syndromic forms of neural tube defects, which are monogenic. So these are like you have, so the other non-genetic actually, which you should think of first, is the amniotic band syndrome, where you have bizarre sort of defects, okay? And then the non-genetic phenotypes that are the monogenic genetic phenotypes, you have a big list in front. They could be the cloacal abnormalities, the lower segmental limb body wall defects, the Kurareni syndromes. There are so many syndromes. But yes, if we have a recurrence, if you have multiple malformations, then you would do it. In isolated neural tube defects, there are many single genes described, but they are mostly susceptibility genes. They are heterozygous, so they're not associated with recurrence. So I don't think as a rule of thumb, you would do an exome sequencing. One would do a microarray, and but not an exome sequencing. And this all you would do if there's no history of periconceptional folic acid. I mean, if there is a good history of having taken periconceptional folic acid.
And what is the MTHFR story?
No, nothing. Never to be done, not to be considered. It is not relevant for that.
So it has absolutely nothing to do with this and all the stories we heard about homocysteine and accumulation and ABCDEFG.
At the end of the day, this could be just because of vitamin B12 deficiency, the high homocysteine. So we know that we supplement folic acid, we can supplement B12. There is now data we can supplement inositol where it recurs, but we will not do MTHFR mutations.
Excellent. Thank you so much for clarifying that. And our last group of lesions, and Dr. Sanjay, when are posterior cranial fossa lesions generally diagnosed with reasonable certainty?
You can suspect at the NT scan by looking at the IT. If IT is more than 95 percentile, we should suspect and follow up these cases. And to actually diagnose, 18 weeks is the ideal time, because posterior fossa structures are supposed to be formed there. Because closure of fourth ventricle, disturbance of Blake-Pause cyst occurs around 18 weeks of gestation. We should have a good excellent sagittal views to diagnose posterior fossa lesions. The brainstem Werman angle, the brainstem tendril angle can diagnose a range of posterior fossa lesions, like from a normal cisterna magna, Blake-Pause cyst, Werman hypoplasia to severe Dandy-Walker malformation. Thank you, sir.
And if there is a doubt at my 19-week or 18-week evaluation, when would you like to call them back? At about 22 weeks, or maybe?
We'd like to do TVS if we can diagnose a little more in that gestation, because 20 weeks hurdle is there for us.
Yeah, thank God that hurdle is now in the background, and we are currently in the business of writing out the rules of the new notification, the new MTP notification. You know, the act is there. And when an act is passed by Parliament and signed by the President, gets notified. And the next step then is that we write out the rules. And COVID is taking up all our time at the ministry, and we're still busy writing out those rules. And we do hope that in the next 2-3 weeks, the rules will be complete. And then we won't have this 20-week sword hanging on our head. Dr. Ratnapuri, the genetics, please, for these dandy walkers and things like that.
Yeah. So we would have a dandy walker, and we would have cerebellar hypoplasia or a pontocerebellar hypoplasia. So dandy walker, again, we need to have chromosomal to be excluded. And I think here I would again like to reiterate that a large number of copy number variants, which are isolated, say if you find an isolated deletion or an isolated duplication, the recurrence risk is small. If in that report you find a deletion and a duplication, you'll do the parental karyotype to look for a translocation. There the probability of a translocation is higher, and there the risk of recurrence varies from 5 to 15%. And if there are monogenic disorders, because again, there is a host of monogenic disorders associated with Dandy-Walker, then the recurrence goes up to about 25% if they are recessive. And if all this is not there, then as you've written, the risk of recurrence is very low. And cerebellar vermis hyperplasia, again, is something that we are identifying a large number of monogenic disorders. In fact, Dr. Khurana, I think I'd like to tell everybody here, with you, we've identified a new gene in that pontocerebellar hyperplasia and have extended it now to about 7 families between predominantly our center and one SGPGI, where they had 1 family with pontocerebellar hyperplasia identified on an antenatal scan and 1 common recurrent mutation in the Indian population. So one of my students has written it up. It's with me now to do all the checking.
Yeah.
But it's fascinating. And I think today is the era of working together. And that's really the message I want to give you, which is what we do in the field of rare disorders. Now, here I talk about working within our community in India because we are so rich in our data. We are so rich in our phenotyping and in our material. So I think if we talk to each other, we can learn a lot and do a lot. And I think that's the way it works. That is the way forward now.
Thank you. I think that is our most perfect message to end up with. We are really pressed for time. Otherwise, I would have asked everyone for their last words. But let me hand it back to our host study group in Nashik before they all start snoring. Thank you so much for this panel. Thank you so much to each one of you on this panel, because it's really been quite an experience preparing for it and discussing it. Thank you so much for making it so successful.
Thank you, Sir.
So back again to our study group for our good nights.
Here to the last but not the least job. And as now all of us are very sure that teamwork is going to lead to the final diagnosis, as I've seen in my case and in all the cases. And I would like to give a big, big thank you to Khurana sir for always guiding us, and who is actually the brains behind this academic dais. I would like to give my sincere thanks to TLN Praveen sir, the president of Society of Fetal Medicine, Bimal sir, who is actually an inspiration and a phone call away, to Mohit sir, who has always been guiding us and helping out small things, being very supportive and inspirative. I'll also thank all the moderators, Gina ma'am, and all the panel members who've given in their precious times and have been guiding us. A big thank you to Vishal Mittal and Conference International for their logistic support. I thank all the trade partners. I thank all the delegates without whom this webinar would have not been the way it is now. And a last thank you to all the case presenters. A very good night and wish you all a very, very happy new year once again.
Thank you.
Thank you, everyone.
Thank you. Thank you very much.
Congratulations,
Good
Nashik,
night.
for such an excellent program. It's your first venture, and it's been wonderfully successful. And thank you so much, Bimal and Mohit, for helping out the entire team.
Pleasure, sir.
Thank you. Thank you very much.
Thank you.
Good night. Good night.
Good night.
Good night.
Good night. Good night.